You will now be placed into conference.
Tools and resources necessary for public health professionals to address cancer as a public health problem. Our main objective for today's presentation is to leave you with a basic understanding of the social determinants of health. Specifically, we hope that by the end of the presentation, you will be able to identify factors that contribute to social determinants of health, describe the relationship between social determinants of health and health inequalities, and discuss how social determinants of health may influence cancer and cancer control. Our presenter for today is Dr. Shobha Srinivasan. Dr. Shobha Srinivasan is a sociologist and health disparities research coordinator in the Office of the Director, Division of Cancer Control and Population Sciences, National Cancer Institute. She is currently the NCI Project Director for the National Institutes of Health Center for Population Health and Health Disparities and coordinating trans-NIH activities to promote intervention programs in Native American communities. Previously, she has taught and conducted research at various universities and has worked as a research director in a community-based health advocacy organization. For several years, she has worked at building partnerships between communities and universities to address various health challenges in underserved and immigrant communities. Her research is focused on social determinants of health, place, and inequalities, including challenges in the utilization of and access to health services. In all of these projects, her goal was largely to inform health policy at the local, state, and national levels regarding care for underserved and underrepresented populations. We are delighted to have her join us today. Before I turn things over to her, I have just a few quick housekeeping items. The archive for today's session will be posted to the Education and Training Tools for Health Professionals page located on cancer.gov next week. We invite your questions throughout today's presentation. You can pose questions live through the operator by pressing *1 on your phone. You will then be placed in the queue for the live Q&A session at the end of today's call. You can also submit questions via the Q&A tab at the top left of your screen. We will get to as many calls and questions today as we can, and we'll alternate between online and live operator. And without further ado, I turn things over to our presenters today.
Hello, good afternoon. I'm Shobha Srinivasan, and thank you for inviting me to speak with you today. I expanded on the title that was given, and I called it Expanding Our Lens, Understanding Some of the Persistent Challenges in Cancer Control. I'm sorry, I'm a little technically challenged here. I have a disclaimer, there are no conflicts. None of it that I'm presenting is the official view of either NCI, NIH, or the Department of Health and Human Services. I hope to offer you today a different perspective to cancer control, and all the data that I present here today is quite universal, meaning they apply not only to the U.S. as a whole, but also is reflective of the local communities in most of the states that we live. So here we are all familiar with this old adage, apples rule, they keep doctors away and genius away with teachers. But I hope to offer this new perspective, saying apples are fine, but I find today's teacher prefers a nice latte. So the overview today is I'm going to talk about persisting challenges, offer some definitions which are accepted by Healthy People 2020 and by NIH and DHHS, and some current data on inequities. And all the sources of data that I present here today are from public sources. None of it is kind of from private sources that you cannot have access to. And I'm also going to talk about implications, what we can do in our clinic and in local communities. So what are our challenges? The biggest challenge is closing the gap between discovery and delivery. We know that the disconnect is a key determinant of unequal burden of disease. For example, if we look at the field of genetics, most of the discoveries now currently may be accessible to only a few in society. So how do we, with greater technological innovation, bridge this widening gap between discovery and delivery? Because these barriers are what really prevents the benefits of research from reaching all populations in society, particularly those who bear the greatest burden, which must be identified and removed. So here is a cartoon taken actually from Canada, from the Premier to Action on Social Determinants of Health. This is something that we are very familiar with in the U.S. We have a very individually oriented preventive action where the individual is trying to get through the system through environmental health hazards, the educational system, food and nutrition, housing, poverty, and the burden is left on the individual. And of course, we do in our work generally focus on the individual, and it lacks attention in all the other aspects that I just mentioned. So what is this individual focus really led to? We have some very innovative ways that we use in medicine, which are some ways to bridge the individual and the system gap. We talk about patient-centered care, seamless care, coordinated care. Yet, nonetheless, it is the patient's responsibility to maneuver finally through the system. Okay, we are familiar with some of these challenges at the individual level. We talk about biology, we talk about genetics, or we talk about behavior, the lack of individual insurance. We talk about race and ethnicity, sex, LGBTQ issues, language barriers, cultural factors, prejudice, and stress. But we all know that the absence of disease is not health. And we also acknowledge that our health is affected by all these factors at the individual level. But there are also a myriad of social factors that affect our health. So what are the larger policies of insurance, larger issues related to access of care, the utilization of care? So in New York, for example, they have hospitals right very near low-income communities, but the low-income communities are really not accessing these hospitals. So just the presence of a hospital in a low-income community does not mean they have access to it or utilize it. There are issues, of course, of cultural competency, language barrier, poverty, there's homelessness, discrimination and racism. All these go beyond the individual and largely in what we term the societal or the structural factors. So I'm going to give you the bottom line right in the beginning. So what is our lens? Our lens is perspectivism, not relativism, but perspectivism. In real estate, we always talk about location. We say location, location, location. So if you live off the coast of Florida, off of Miami, or you live overlooking St. Mark's Square in Venice, it is the best location and it's very expensive. And it costs much more than living maybe in Detroit, Michigan or Pine Ridge, South Dakota. So the context where we live determines our perspective. And also determines our options, determines the choices we are given. So we need to contextualize the community people live in. And that is very important for us to serve in healthcare. So the cancer patient is beyond cancer and beyond just being a patient. Okay, so the takeaway point is context. I said we know some of the individual factors, and we know some of the social structural factors, which we don't focus on so much. But what we focus even less on is how they interact and impact each other across the life course. Most of our work so far is single cause oriented. So let me show you a graph here. This is put out by the Robert Wood Johnson Foundation. It says across America, differences in how long we live. The yellow circles are places where people live the shortest, and the red are where people live the longest. Now you're saying, oh, well, yeah, I can see South Dakota, I can see Arkansas, people having low levels of longevity there. But that overlays very beautifully with the poverty levels across America in the last 12 months. This is 2009 data, and this oops, I wanted to go backward, but I think I am having a, okay, here we go. So you see how in South Dakota and how in South Carolina and in Arkansas, the rates are, the longevity is short. So then you overlay it and you see all the dark blue where the poverty is very high. So we could say actually it's not cancer that's the disease, it's poverty that's the disease, right? But then that would be again a very simplistic model. So what do we generally know? We know individual factors. We identify high-risk populations, and we account for factors such as biology, genes, and behavior. We talk about smoking, we talk about genetics, we talk about metabolism. But generally, what we ignore is the context and role of the social determinants of health. It's acknowledged, it's measured, but it's generally controlled or held constant in analysis. So where a person comes from, what are the various acts they have to care from childhood is something that we don't provide them too much. So before we move forward, let me offer you some definitions. Most people across America especially are very familiar with the definition of health disparities, which are differences in incidence, prevalence, mortality, and burden of cancer and related adverse health conditions that exist among specific population groups across the U.S. These population groups can be characterized by gender, age, ethnicity, education, income, social class, disability, geographic location, or sexual orientation. However, in the U.S., we mainly look at health disparities by race and ethnicity. Here is another definition I offer you. The health equity is now creeping into the U.S. health lexicon and owes its genesis actually to the World Health Organization and now is being adopted by the Healthy People 2020. And as you see, I have taken the quote, the definition from Healthy People. The health equity here is the attainment of the highest level of health for all people. What is important in this definition is not just the differences, but it has two very important strands. One is improving the average health for all and addressing those avoidable inequalities in health. And that brings us to the social determinants of health, which are the avoidable aspects. So in order to achieve health equity, it means talking about social determinants of health. These are the conditions in which people are born, grow, live, work, and age, including the health system. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable factors in health statuses seen within countries and between countries. So some of the factors to consider in social determinants of health. There's income, there's poverty, there's education, there's hunger, housing, you can look at it as neighborhood and place, urbanization and crowding, employment, and health care insurance. It's important to acknowledge that I am focused here today on the avoidable and those factors that can be changed. So I want to acknowledge the role of race and ethnicity. We consistently see the effects of race over and above the effects of socioeconomic factors in many of the things that we talk about in health. We also have to acknowledge is the lack of data in certain areas and literature in some places does not mean that everything is going well. For example, we have very little literature and data among Native American communities and their health status and the survivors amongst them and what are their health challenges. That doesn't mean that those issues don't exist, the lack of data. Also, immigration. Immigration is a paradox in the U.S. Though immigrants are the healthiest when they come into the U.S., there's a dramatic change within one generation, and their health becomes worse than the dominant population within the U.S. All these put together only further create inequities, and the communities get further marginalized. So let me give you an example of social determinants of health and health inequities. Okay. Say, suppose we're talking about unequal distribution of resources, such as housing. So we no longer can, according to the law, tell people that, you can't afford to live in this community, you need to live in a poorer community, and so on and so forth. But if you walk down the road, you can see clearly on one side of the road, it says houses between 50K and 100K, and on the other side, houses between 200K and 300K. And these two communities may have totally different access to basic education. So there's a lack of basic infrastructure in these two different communities. Then this results in kind of inequitable access to resources, where you have limited health care, insurance coverage, and transportation. We know that there are limited healthcare facilities with limited hours in certain areas, and only a few doctors available, and people have to travel sometimes over 300 miles. There is also unjust health and healthcare practices, where we don't offer, of course, it's a radical word to use the word discrimination, but we do it unintentionally and sometimes intentionally too, where we don't offer a poor person who comes into the hospital the same treatment options or care options that we offer a person who has health insurance. So all this results, of course, in persisting inequity. So let's go to some current data on social determinants of health and take it from there. So the income in 2010, the median income in the U.S. now is $49,455. It's a 2.3% decline from 2009. The average income for an individual in the U.S. now is $67,976. So if you go back to your basic stats classes, when the mean is higher than the median, you know you have a larger number of people who are poorer than those who are well off. 19% of all households in the U.S. had an annual income exceeding $100,000. The bottom third of the U.S., 30% of them, earned less than $25,000 a year. Now, I want you to remember that $25,000 a year. What can our money buy? In 1967, if you earned an average of $6,000, you were actually able to buy something worth $41,000, $40,770. In 2000, if you earn nearly $39,926, your buying capacity was that of $53,164. So you see the decline here. But now, in 2010, if your income was $47,000, your buying power is only about $49,500. So that means income is an important factor in our buying capacity. So this is the income, and you can see here how the Asians have an average income of $64,308, and the whites are below at $54,000, and blacks earning the least at about $32,000. But if you look at this, you can't say all minorities have a low income. So you cannot look at society merely by race and ethnicity. So income and poverty are highly linked, and poverty in the U.S. has increased in the last 10 years, and now it stands at 15.1%. That means about 46.2 million people are below the poverty line. So what is poverty? If you remember, I asked you to remember $25,000, right? I said 30% of America earns less than $25,000. The poverty line is at $22,314 for a family of 4 in 2011. Also, I want to trigger your memory about what is a buying capacity with that money, which is much, much less. And you have to remember also, median individual income is at $49,000, and also, I repeat, there's 46.2 million people who are below the poverty level. This gives a breakdown saying who is the poorest. The highest poverty rate is in Mississippi, and 18% of children are below poverty, and 9.8% of people who are 65 and above are below the poverty line. Now, the poverty line I've given you is for a family of 4, so the individual poverty level is much lower. So poverty and education have this wonderful cyclical relationship, and I mean wonderful in a very facetious way. So why are poverty levels very high in the U.S.? It goes back to lack of education, lack of good educational infrastructure, no job, no money, that is no income, a cyclical relationship. Lack of education has implications for health and cancer education and awareness, and subsequently, for cancer control and health of the nation. So why is education important? Look at those folks with advanced degrees. They earn an average of about $78,000. And if you have no diploma, that means you're a high school dropout, you have about an average income a year of about $19,000. This is data from 2004. It hasn't really shifted. So when I say education pays, look at this chart here. The red shows the unemployment. The green shows the median weekly earnings. The bottom-most one shows less than high school diploma, who have the least income of median weekly earning of $444 and the highest level of unemployment, whereas those with doctoral degrees show an income of $1,550 or professional degrees with $1,610 with very, very low rates of unemployment. So if you go look at poverty rates by education, we see high school dropouts, the red line on top, having the highest level of poverty. And it is then you kind of, and the dark blue line at the bottom shows the college graduates, which have the lowest level of poverty. Effects of poverty can be felt at a very, very young age. We see here children living below the federal poverty level were most likely to be chronic absentees in elementary school grades. Now, when you are absent during your basic education, where you're learning your A's and B's and your math, the dropout rate becomes much higher from high school completely. So this is indicative of those who never finish high school. So if you're below the federal poverty level, you're more likely to drop out than if you're above the federal poverty level. So the poor have the highest levels of absenteeism, which is linked to dropout rate, continuing the cycle of poverty. Jobs are very important, as we know, in the U.S. because most of our jobs are ones that provide us with health insurance. So, but however, I just want to note that though this data is from 2008 and 2009, in 2011, the percent of private insurance offered by employees has gone down. So we see here any private plan right on top being the highest, whereas people who are on Medicare, Medicaid, and military health care have the lowest number of rates of insurance. So what is the uninsured rate in America? 16.3% of people in America are not covered by any kind of health insurance. That's nearly 50 million people, and the recession has only increased that. Though the rate has not dramatically changed since 2009, at 2010 it stands at 16.3. And as I started out telling you earlier, location does matter. Most of America lives in urban areas and very few in rural areas. We actually have a bimodal distribution in America of health based on those living in inner cities who have the worst health, as well as people living in rural areas also who have very bad health. This is largely because of the kinds of services that are provided in both these places. The National Health Interview Survey a few years back reported that a child that moves from inner city to the suburbs improves his or her life expectancy by 15%. So that should give us pause for thought. What are the implications for cancer control? So we have seen falling income, high levels of poverty, high levels or lack of insufficient healthcare insurance, declining higher levels of education. So what are the implications? Before I move forward, I just want to point out to you that all our prejudices or all our learning and our perspective is influences even how we interpret data. For example, there was a paper published on racial differences in use of colonoscopy, sigmoidoscopy, and barium enema in Medicare beneficiaries, and they concluded that Black men appear to be vulnerable to underuse of colonoscopy and sigmoidoscopy. But during the Affordable Care Act debates, we heard that having health care insurance really shouldn't matter to the community because Blacks don't get care anyway. So my question is, what is the context here? So if you are 65 and you don't go for colonoscopy, does this mean that you don't care about health insurance? Or does it mean that the context in which you grew up did not promote prevention? So let's look at family income and cancer incidence. This data, as you see, is from 2009, and it shows you that people who have lower incomes have a higher level of all cancers, and the level decreases using 50,000 and plus as the baseline. You see people who have less than 12,000 and people who have less than 25,000 have the highest levels of cancer incidence. And this is largely due to the high levels of stressors, environmental degradation, and interaction with genes causing unique phenotypes. Additionally, lack of income, high poverty means lack of adequate care, especially preemptive care. So here is data actually taken from the Cancer Trend Progress Report, which is currently being updated. So this is data from 1987 to 2010, and you see actually there is racial difference in mammography rates among women 40 years and older. So race does not really tell us the full picture. However, if you look at whether they had mammography based on the federal poverty level, you see those below poverty level, 200% below poverty level. The black line is much lower and dramatically lower to the blue line of people who are above the poverty level. And if you look at it by education, you see people with less education having very low rates of mammography screening, whereas people with higher, greater than high school education having higher levels of screening. Though the rates have gone up for all and the slope is very similar, there still persists, a gap persists between the groups. Now let's look at colorectal endoscopy by race and ethnicity. Here we do see some differences, with Hispanics having the lowest rates, and the slope is much steeper here for Hispanics, which is the purplish pink line. And I'm sorry that the colors are not so vivid. I thought it would be, but it didn't come out that vivid. But you see that the Hispanics, the trajectory and the slope is much steeper, meaning they are catching up with the other races, which have pretty similar colorectal endoscopy rates. If you look at colorectal endoscopy by poverty, you see the dramatic difference in the two. The slope for those, the blue line, light blue line, who are way above the poverty level have much higher rates, nearing 70%, whereas it nears only 50% for those who are very much below the poverty line. And again, if you look at those who had ever had any colorectal screening, meaning putting together FOBT, endoscopy, and colonoscopy, those who are the poorest have the worst rates of screening than those who are better off. And here, too, the rates are about 70% for those who are better off, and for those below the poverty level, it is about 52%, I believe. So let's look at an interaction here. Here is colorectal cancer screening prevalence by health insurance. You see that in this category, the people who have had private insurance have the highest level of screening at 55.1%. The uninsured have the least, and the uninsured currently are at about 20%. So insurance does determine to a large degree whether we get screening or not. So let me put several social determinant factors together from a study done by University of Illinois in Chicago, and which actually it is under a program where they look at basic biological factors as well as behavioral and neighborhood factors to determine the issues that affect late-stage breast cancer diagnosis among African American women. Here, most of us, when we see the word urban renewal, we think of it as a very positive thing. But what happens in urban renewal or gentrification? The communities that are poorer get left behind in areas that are gentrifying or being renewed. So you will find a house where there are people with median incomes of 100K plus with someone else who has an income of 20K and below. So what happens when a neighborhood is in that kind of a transition? This neighborhood originally could have had a federally designated healthcare center. Now, with the income of that neighborhood increasing, average income increasing, it loses that status and it no longer will have that status. So these women who are left behind no longer have easy access to healthcare or any screening facilities, and the utilization of any kind of health facility becomes more difficult. In this case, it leads to basically a lot of isolation and greater levels of stress. So we see if you are a low-income person, your chance of having a late-stage breast cancer diagnosis in a neighborhood that's being gentrified is 23% higher. And if you live in a neighborhood that has a higher level of concentration of immigrants, it's 11% higher. And if you are African-American woman who's been left behind in this area, you're 24% more likely to have a late-stage breast cancer. So the odds of a late-stage breast cancer is determined, of getting a diagnosis and being treated, and the survival is determined by where a person lives and the kinds of neighborhoods that they grow up in. So I started off with this cartoon right in the beginning, and I said, we are all individually oriented with preventive action. And I showed you some data where we find that education matters, insurance matters, where need matters, the kinds of housing you have matters. So what is really needed is to improve our odds instead of saying against all odds. And what would that mean? It would basically mean a community and a population-centered approach where we remove those health hazards with the community, help of the community and a population-centered approach, and we have concerted and sustained social policy to lessen that slope, so that we no longer have an individually oriented preventive action, but we have a community or a population-based preventive action to improve our odds. So what is the implication for cancer control? I know you're all listening to me here and saying, okay, poverty, education, infrastructure, what can I do about that? These are all at a much higher level. But there are a lot of things that we can do at the local level. So in building momentum, in building your community clinics, in building your communities that account for cancer screening, that promote cancer screening, that promote cancer control, you account for the context. Because the people who walk into the clinics, walk into your offices, are living in neighborhoods with all those issues that I talked about. So you have to also understand, when you apply the studies that you have read, you have to understand from those studies who is included and who is excluded from those studies and surveys that you have. What is the context in which these measures are given to people? We find that a lot of people are asked whether they are stressed, and people shrug their shoulders in low-income communities and say yes. Or they say no, because they live with it so much that they don't even recognize it as stress. So in Chicago, for example, they found that women weren't coming for their cancer treatment because they were living in terribly violent neighborhoods and were afraid to come home after the treatment feeling sick and not being able to make it back home. So how do you measure that? And also, as I pointed to you, that we can show our prejudice by our interpretation of data. So statistical methods, they can be very, very nuanced. So we have to know what is controlled, what is not controlled, what is accounted for. It's very important, actually, to have partnerships with the community. And when I say community, there are levels of community of scientists, communities of nurses, doctors, professionals, and the community which is served. You know, scientists sometimes can be skeptical, scientists, doctors can be skeptical professionals, because all these kinds of partnerships take time, resources, and a lot of energy. Also, on the flip side, communities can be reticent. You can go and say, I want to do cancer control, and I want to promote screening. But what their issues are may be high BP and cardiovascular health. So how do you incorporate a cardiovascular health within a cancer control program? So these partnerships between scientists and communities is ongoing and an everyday affair. It's not once a month or once in 6 months when the community advisory board meets. So when you have community advisors, also look for that feedback loop with them about what you are doing with the community so they can tell you what they can do for you. A lot of the time, communities can do much more for us than we give them credit for. What is very, very important in all this process with feedback loops is the building of trust. So if you have a set of community advisors and you're going and talking to people, it's very, very important to show exactly what you can do, tell them the limits of what you can't do, and that would probably help in the long run. In applying whatever you do, ensure cultural relevance. What does that mean? Alaska, for example, cannot really adopt many of the interventions that are done in the lower 48. So if you have an intervention that requires frequent contact with the people, it cannot be possibly done in the summer when people go away to very remote areas where there's no even cell phone contact for a month or so. When you talk about health literacy, it is not that we are talking to people who don't understand what we say, except that we talk in languages that people cannot understand. Because people are not well educated, that does not mean that they don't understand. They do understand, especially the attitude that we have towards them. In educating, especially for cancer control and awareness, you have to kind of balance the evidence and best practices. Sometimes the evidence-based approaches may not work where you are, and best practices is what you need. Does the community where you work have access to care and the support that you can provide them? And do they have the kind of support that will help them move the community to better cancer control mechanisms? How are the institutions where we work? How are the services provided? Do we generally tend to provide services which are convenient to us or which is convenient to the community? I'm originally, if I could give a personal example, I'm originally from India. I was used to, as a child, going to see the doctor very early in the morning, 6 to 8, or after 8 in the evening. Most of the doctors did not function during the day. So what does it mean? We have to, in all that we do, think at the population level, but act totally at the local level. So I end with this. The I in illness is isolation, and the crucial letters in wellness are we. And healthy communities have hope, and those who have hope have everything. And the two pictures here are actually taken from Haiti, right after the tornado hit.
Wow, thank you for such a thoughtful and thought-provoking conversation. The second half of this call will be devoted to your questions, and we encourage all of you to be active participants. I'm sure that you have many questions following that fantastic presentation. As a reminder, please press *1 to be placed in the queue to ask your questions. If you would prefer, you can also submit your questions using the Q&A feature at the top of your screen. Operator, we're ready for questions, please.
Thank you very much. And I would just like to remind participants, once you press *1 to record your question, please record your name so that I may introduce the question. Our first question we had in queue comes from, I believe the name was Kay with the University of Minnesota. That line is now open.
I am just wondering about the source of the data that was presented, particularly on the relationship between poverty level status and colorectal cancer screening. Thanks.
It's the data is from the Cancer Trends Progress Report, and the data that is there on the website now ends at 2008, I believe, and they are currently putting up the data for up to 2010.
Thank you.
And once again, just to remind participants, it is *, then 1 if you'd like to ask a question on the phone. One moment, please, to see if any other questions queue up. One moment, please. We do have another question queuing up right now. Our next question comes from, I believe the name was Noel with Washington University in St. Louis. That line is now open.
Hi, my name is Noel, sir. I was just wondering if the presenter could say something about stage of presentation versus socioeconomic status.
Well, the data that I presented, some of the data that I presented, we find that in lower income communities, they present at a later stage because of lack of facilities for screening and lack of utilizing the care. And there's a myriad of factors that are associated with that. Firstly, in some communities, it is just that screening is not available very easily. And this I'm referring to Native American communities generally, and also in some of the communities across the borders, in the southernmost borders across America, where a lot of screening facilities are not available. So the presentation of the disease is at a later stage.
Thank you.
So we do have one question that came in online. Angelina wants to thank you for your presentation, and she really thinks that the information is helpful to frame the discussion about social determinants in cancer. And she was wondering if you would be willing to address the issue of provider bias, which is not directly related to social determinants, but may be influenced by our experiences.
Actually, there's been quite a few studies done on provider bias. About John Snow Incorporated has done several studies on looking at where they have performers present conditions to doctors, whites versus blacks, looking like a professional versus not looking like a professional, and women versus men. And they have shown that when people present in a more professional status the same kind of symptoms, they tend to get more options for treatment. But they also find differences in when people were trained across the U.S. They found one of the studies, I don't want to misquote anyone, they looked at people in various generations and differences between male and female providers and how they respond to these kinds of situations. There's also been a lot of studies done on provider-patient communication and how that enhances. I believe recently I was reading something about Carolyn Clancy, who is the director of ARC, and she actually talked about how she was walking down the hallway of a clinic, a federal clinic, and she was very impressed with a pharmacist who was talking to a patient, gave him a whole set of instructions about his medications, and then turned around and asked the patient to repeat it back to him. So this simple exchange enforced exactly what the patient should be doing with the drugs he or she was receiving.
Operator, do we have any additional questions on the line?
Yes, we do. The next question queued up comes from Carolyn. That line is now open.
Yes, I was wondering how you combat the cultural beliefs which keep patients from going for preventative care like cancer screenings while they're asymptomatic.
Cultural beliefs are a very interesting agenda because in many of the issues that we have in low-income communities and people with less health literacy issues, prevention has not been something that we have trained people with from childhood. We only have trained people to go to the doctor when you present some symptoms and it is major. So I think it is a matter of education, a lot of education on health literacy, and how do you communicate that education through trustworthy sources. It is also who is telling folks that they need to get care and need to access those care. I think these cultural beliefs can be dealt with. We have a lot of issues on cultural beliefs and why we shouldn't talk about issues, especially in breast cancer in certain communities or about ovarian cancers. But I think it is a matter of slowly getting communities to talk about it with those whom they trust.
Thank you.
And that's actually a very timely question, and I'll give you a preview of our next coming attractions. Our next session is actually going to feature that very topic of cultural relevance and health literacy, and Dr. Kathy Mead is going to be our presenter. So do look for that announcement coming up in the next couple of weeks with the date and time. So, operator, are there additional questions on the line?
At this time, I've had no additional questions come into the queue.
So just two quick things before we wrap today. There was a question that came in online about this quote that Shobha ended her presentation with, and it is now available on the screen for you all to read for those of you who had additional questions about the actual wording of that quote. So it is now up and available. We do want to thank you today for your participation in our seminar, and it was a great kickoff to our 2012 season. Your feedback is very important to us, and we encourage you to complete a public comment form that will be emailed to you shortly following this call. So as I previously mentioned, our next call is going to focus on cultural relevancy and health literacy, and Dr. Kathy Mead will be our featured presenter. We are working to schedule that conference call right now, so please look for an announcement in the next coming weeks about the date and time. And as a reminder, our last semester of Cancer Classroom included sessions on cancer screening and diagnosis, cancer treatment and survivorship, Clinical Trials 101, and Clinical Trials 102. In case you may have missed these webinar presentations, the audio files are posted to the Education and Training Tools for Health Professional page on cancer.gov, and we do provide closed captioning for all of these archived sessions. So we hope you've enjoyed today's session and found the content useful. Thank you all for joining us this afternoon, and have a great day.
That concludes today's conference. Thank you for your participation.